evening, ladies and gentlemen. Welcome to another evening and another episode of the post-COVID rehabilitation and recovery series. My guest this evening is somebody very smart and very nice. Dr. Hooman Poor is an assistant professor in the Department of Medicine, Pulmonary Critical Care and Sleep Medicine Department, as well as the Department of Cardiology. He is also the originator of PERT, which, if you don't know what PERT is, it is the Pulmonary Embolism Response Team, which sounds very exciting. Welcome, Dr. Poor. Thank you so much for being here this evening.
Thank you for inviting me, Noah.
All right, so our crew tonight is a combination of patients, clinicians, many long haulers, but what I'd love to talk about, and I know that you are really on the super front lines, and I'd love to just talk a little bit about what you were seeing initially and how that's kind of evolved for us over time.
Yeah, I mean, this has been, feels like it was decades ago when this first came, and it's only been, a few months, which is frightening. But, we were obliterated here in New York early in, March, April, May. And part of the issue that was so complex was beyond just the sheer number of patients and the acuity of disease, but the fact that we didn't even really know what we were dealing with. And part of the problem was that this disease, particularly the most severe form where patients are in the ICU, has been characterized as what's called the acute respiratory distress syndrome. And that's a respiratory disease where there's inflammation in the lungs, usually from like an infection like the flu or some other kind of inflammatory process. And that inflammation causes fluid to build up in the lungs, and it makes oxygen difficult to kind of get into the body. It makes the lungs stiff, and people have respiratory distress and they're on ventilators. And we've had decades of experience of how to treat that, and we know optimal management and so on. But we were kind of tricked with this virus because there were a lot of characteristics that were very different compared to regular ARDS. And, as a result, people were doing all kinds of different therapies and different tests to figure out what was actually going on. And we're still learning, what this disease is about. Early on in Mount Sinai, we have ICUs that are specific for, specific conditions. We have a medical ICU that has 14 beds. We have a cardiac ICU that takes care of cardiac conditions, a cardiothoracic ICU, surgical ICU. All of these ICUs were converted into COVID ICUs. And all of these patients that were on ventilators were put in these ICUs, and then additional ICUs were filled with these patients. And we had something close to 120 or so patients at one time on ventilators. We were putting 2 patients in one room often because we couldn't, manage this. We converted the entire lobby into beds, which I don't know if you've been into the Mount Sinai lobby. It's this big, atrium. They shut it down, and they literally brought in engineers and construction, and they built, tons of beds. We didn't actually ultimately need to use it. Central Park had, patients who were on ventilators. And so it was, a horrifying moment at that time where patients were extraordinarily sick with a disease we didn't know how to treat. We didn't really understand. Thankfully, over time, things improved from the standpoint of the numbers going down with social distancing and guidelines to prevent disease transmission. However, I'm concerned that it's coming back now.
Mm-hmm. Mm-hmm. Do you think that, as far as, one thing that I saw is that a lot of people who I think normally would have been admitted to the ER were told to stay at home. Or people would show up to the ER with, or would be taken by ambulance, who would at any other time be certainly admitted to the ER, if not the ICU. And they were not even admitted oftentimes, or not even allowed in because they were told they'd probably, swing it. Do you think that that played a role in let's say long haulers or people who are known as long haulers?
I mean, to be honest, I don't think that was at that time the wrong thing to do for a number of reasons. The first is it would be one thing if we had a therapy to offer. That if we had something to say, take this drug, take this therapy, it will make you better. Come to the hospital, we can give this to you. But instead, what ends up happening is at that time, patients would come in and they would be put in a room. They could have no family members. You're all alone, with overworked, overwhelmed staff. And if they weren't as sick, they probably would be better off at home. I think the situation is a little bit different now because we do have therapies, and we do have a better understanding of the disease that can help, alter the course of the disease. It's not groundbreaking. It's not like a therapy that cures all. But I think, if patients are sicker and they do show up earlier, we may have therapies and interventions that ultimately help outcomes early on and perhaps later on.
Gotcha. What I would love to do is I would love to start with the respiratory system and then go to cardiac. What are the things that you saw early on? And for people that were not admitted to the hospital, that are long haulers now, that are having difficulty getting care, what testing would you like to see them get? And, what things would you be looking for?
Yeah, I mean, so as I was going back, the main issue with this disease is we still don't understand. We're characterizing the severe form of this as acute respiratory distress syndrome, and what we started to recognize was that their lungs were not that stiff, and as a result, there were also many patients who had very low oxygen levels that were not in respiratory distress. This is sort of the hypoxia, patients with very low oxygen levels, but just send in there kind of texting or, and that's a sign that the lungs are not stiff. And so when that's the case, the first kind of part of the lung that we start to question if it's affected are the blood vessels of the lungs. And early on when this was happening, the way many patients kind of presented and looked, they all looked like they were having blood clots in their lungs, quite frankly. And as a result, we started giving therapies like breaking blood thinners and giving medications to break up the clots. And there's a lot of unfortunately autopsy studies that have shown that there are kind of blood clots in patients, and so that seems to be playing a role. Another thing is that it seems that many patients have very abnormally dilated blood vessels of the lungs. So the blood vessels of the lungs are not constricting appropriately. They're very dilated. Too much blood is going through them, and as a result, oxygen levels are going very low. And so this is a problem that clearly affects the blood vessels of the lungs, both causing them to dilate and also causing them to form clots. But it also causes inflammation in the lungs. And for some people, that inflammation seems to get better. For some people, that inflammation results in scarring. And as a result, that scarring results in exercise intolerance and inability to do the things that they were able to do prior to the disease. And that's not to mention all of the other organ systems that are often infected as well, including things like the kidney, neurologic issues, the heart. And so it's again only been a few months since this disease has come here. So we don't have obviously experience or data with respect to the natural history and what the course of this is. I've seen a number of patients in my clinic who've had COVID, either patients who've had it and have stayed home and weren't very sick, but are still having kind of persistent symptoms that are intermittent, they come and go. And then I have patients who've been very sick in the hospital, who've had significant scarring in their lungs and other issues related. We don't know what the course of this will be, whether this will get better, whether there are therapies that can help alter the course of this. It's unfortunately a black box right now.
So, I mean, I think the question that everybody has is the scarring, is the scarring ever going to go away? I've heard people say, typically no. Is the scarring going to be progressive? And I guess the answer is still, we don't know at this time.
Right. The unfortunate aspect is we are extrapolating from other diseases and other conditions. And so that's why, when someone has classical acute respiratory distress syndrome from, say, influenza, and they have a certain finding on their CAT scan later on, we know exactly, the likelihood of what will happen. Here, we can say it might be similar to that, but you would be foolish to do so. And part of the horror that I had during the initial COVID, spree was that patients were not behaving the way that we expected to behave acutely. In that generally when they're on ventilators, they require a ventilator. Basically is a machine that pushes air in so that you don't have to pull air in, and it also can deliver high amounts of oxygen. And so the way that we know that a patient is getting better is that we don't have to push as hard, and the amount of oxygen we give goes lower and lower and lower. And then, patients get better, and then we take the tube out, and all is good. And that's usually how the acute respiratory distress syndrome, behaves. Patients with COVID, and again, the PTSD I have from this is that patients would get better, and then they would, the tube would come out, and then all of a sudden they would have a cardiac arrest out of the blue, or all of a sudden, the tube would go back in, or all of a sudden, and it was this, unclear natural history of, pretending like we knew, like we had control of the situation and we understood what was going on, yet it was just all over the place, and it was very hard to predict. On the flip side, there were times when patients were on the ventilators for weeks upon weeks upon weeks upon weeks, and under any other circumstance, you would give a prognosis to a family and say, given the experience that we have with patients with, classical ARDS, and, the survival or functional capacity of your loved one is close to zero, and they would walk out of the hospital. And so I kind of have the same, view of the long-term complications of this, in that, quite frankly, I don't know. And I think it needs to be properly studied, in the sense that, perhaps this is a short-term effect, perhaps it's a long-term effect, perhaps it's an intermittent effect. And, you of all people know better than most that, shortness of breath is not from one cause. And there are, many, many different causes of shortness of breath and inability to exercise, because all of your organs work, together to help you do the things that you need to do, and do them well, and do them, at high levels. And when one or a couple of them are off, you can become limited. And so that includes things like, your lungs, in terms of how well they can expand and not, the blood vessels of the lungs and how they can extract oxygen, the heart and how well it pumps, the blood vessels everywhere else in terms of how it can, regulate blood flow, how blood can come back to the heart. And then even just the sensation of breathing, and the sensation of everything that's going on, all of these things can possibly be altered. And, we need to figure out, does everyone end up in the same way, or are there some people that are like type A and type B and type C, and we can, treat them accordingly. But what I can say is that, it definitely has affected people long-term. Patients I've seen steadily make, improvements, but, the concern is that at some point in time they will plateau, and that plateau is not back to their normal baseline, or something that they would find appropriate.
Yeah, I have a similar feeling to you, which is that there's kind of like everything that I thought I knew pre-COVID, and then it's like everything post-COVID is like brand new start, because chest pain doesn't mean what chest pain used to mean. Shortness of breath doesn't mean what shortness of breath used to mean. And with this group, I've spent a lot of time with long haulers, and it's like 100 people could have the same symptom, and it can come from something totally different. Mm-hmm. Really fascinating, and scary at the same time. Can I ask you to explain a little bit, what does it mean when somebody has ground glass opacity?
Yeah, so when we look at a CAT scan of the lungs, the CAT scan of the lungs, the lungs are obviously filled with air, and you should basically see black stuff, and that's a normal lung with some areas of, where the vessels are, and where the airways go. If there's white stuff in the lungs, and that white stuff doesn't completely obliterate the image, and it looks like ground glass, kind of crushed glass, and you can see the underlying images. Um, that's ground glass opacities, and that is a reflection of essentially fluid in the air sacs. And that fluid in the air sacs can occur because the capillaries in the lung, the blood vessels in the lungs are leaky, and when they leak, they spill over into the air sacs. And when that happens, obviously, oxygen can't get into the blood vessels of the lungs in that area. And so, that's one of the ways, obviously, that COVID causes this issue.
And that's different than fibrosis, correct?
Right. So fibrosis is, so again, this is the kind of the classic acute respiratory distress syndrome paradigm. We call this also acute lung injury. So when the lung gets injured, so the lung is basically made out of airways that lead to these sacs where capillaries or blood vessels go by. And when they meet, that's where gas is exchanged. Oxygen goes into the blood and carbon dioxide comes out, and then you breathe that out. When there's inflammation in the lungs, say you get an infection or you have an infection in your body, these capillaries and the alveoli, which are the air sacs, can become very leaky. And when they leak, fluid leaks into the air sacs, and as a result, gas and oxygen can't go in here. And when they leak into the lungs become very boggy and very stiff, and it's very difficult to breathe in. The lungs over time will try to heal that. And whenever you, for example, injure yourself, you get a scar, and that's your body's way of healing. Your body does the same thing in your lungs. Ideally, it wouldn't form scars, but in some cases, it will form scars, and that scarring makes the lungs even stiffer. For now, we view scarring in the lungs as sort of a permanent situation, that something that doesn't go away. But with all things COVID, nothing is kind of set in stone.
We don't know. So is it accurate to say that if you do see a CAT scan with ground glass opacity, that there's a possibility that that's going to resolve over time?
Yeah. So when you compare this to, because there are many lung diseases, obviously outside of COVID, where we see patterns that look like ground glass, and we see patterns that look like scarring fibrosis. And in general, the patterns that have the ground glass, those have a reasonable probability of going away. Those that have scarring and fibrosis don't really ever go away. There is the possibility that the ground glass kind of converts into fibrosis, because that is, for some people, a healing process. There are some lung diseases where the main problem is a abnormal way of healing. You just start forming scars all over the place in the lungs.
And what would be a classic treatment like for ground glass opacity, if there is one?
Right. So, if the ground glass opacity is because of inflammation, the treatment really is to tame down the inflammation. And the therapies that we use to tame down inflammation include, things like steroids, corticosteroids. And in fact, steroids are one of the treatments that we have that have, with a clinical trial, demonstrated a survival benefit. And so that is something that patients who have that, we give them steroids. And so if you treat the underlying infection and the underlying inflammation, then those ground glass opacities will ideally go away and lead to outcomes that are good. The other things that, remdesivir is an antiviral drug against the virus that has clinical trials that have demonstrated improved outcomes. So those are really the two main therapies that we have that seem to improve patient outcomes. They don't cure you, like it just simply reduces the percentage of people that get worse. And it does, have a benefit in terms of survival. All the other therapies are kind of still being tested out. And, there are 1.5 million clinical trials right now, looking at different kinds of anti-inflammatory drugs, drugs that target very specific pathways that cause the inflammation. I'm running a clinical trial on drugs that break up blood clots in the lungs for a subset of people. So again, it's not a one-size-fits-all type scenario, but that's what ground glass is.
Thank you. One of the challenges that a lot of our patients have had is they have certainly earlier on, they had difficulty with people taking their symptoms seriously. A lot of people thought that it was in their head or anxiety or things like that. When should somebody really insist or seek out the help of a pulmonologist?
I mean, I think, you know, symptoms being in your head is a possibility, but it should be the absolute last possibility. In that, you know, there are, as part of the causes of shortness of breath, there are neurologic and psychiatric reasons why someone can be short of breath. But we view that, or I personally view that, as what I call a diagnosis of exclusion. And so personally, when you evaluate a patient who has shortness of breath, period, the things that you want to really evaluate are things that are dangerous that you can do something about, or things that, you know, if you don't catch or you don't identify, they will get worse because, you know, you would otherwise have had therapies to have addressed it. Doing diagnostic tests that will just identify, you know, something that there's no treatment for. You know, if it's non-invasive, by all means. If it's invasive, then, you know, that's something that might not be so helpful. But part of this is that if you are having symptoms, I think it's appropriate to bring them up to your, you know, healthcare professional. And if they're not being taken seriously, then I think you need to see a new doctor. It's being taken seriously doesn't necessarily mean do every test in the book. It does mean, though, to have someone that's listening and addressing those concerns and trying to, you know, put the pieces together as to why or why not certain organs and systems may or may not be, you know, functioning well, and what needs to be done going forward.
Gotcha. And can you explain what the difference is between, like, what can you find out on a chest X-ray and what could you find out on a CAT scan? And then what's the difference between contrast versus non-contrast?
Yeah, so a chest X-ray is just a very blunt tool where the X-ray beams go from front to back, and you look at the film and you see this two-dimensional image of the lungs. The lungs and the chest and everything, as you obviously know, are not two-dimensional. It's three-dimensional, and a CAT scan is basically many, many tiny, tiny X-rays that go down like this, and we can look at it kind of like slices this way. We can look at it slices this way. We can look at it in many different ways. And so it gives you very fine detail as to what's going on in the lungs. When you are trying to look at the blood vessels of the lungs, particularly when you're looking for blood clots, you would need something that lights up during the CAT scan, and that's when we give intravenous contrast. And so in the hospital, when we're concerned about blood clots and pulmonary embolism, that's the treatment of the diagnostic test of choice is a CT of the chest with intravenous contrast.
Gotcha. Thank you. And do you have a sense, like, so many people wind up with normal tests, so normal chest X-ray, normal CAT scan, in many cases normal PFT, but they're still short of breath. Any thoughts on that?
Yeah, and I that's probably the most aggravating situation, and it's a little presumptuous, I think, for someone who has those symptoms to tell a medical professional that they're having those symptoms and tests are done and the medical professional says you're fine, because clearly that patient is not fine. And it simply is that those tests have not elucidated what's going on. Unfortunately, I personally have seen a number of patients who've had this situation where at the end of the day, patients have exercise intolerance and they get short of breath, and it's unclear why. But I think you know, there are many, many possibilities. I have a lot of kind of research ideas as to, you know, what possible things could be going on in some of these patients that can cause shortness of breath. But it will take time and you know, large studies for this to be kind of better characterized. The one thing I would say is that, you know, listen to your body, and if you are having symptoms and if you are short of breath, to acknowledge that that's the case and to realize that you're not crazy. you've had, an infection that's doing something or has done something, and that, hopefully with time, there will be more answers that will help elucidate what's going on, and ideally therapies to make people feel better. On the flip side, maybe your symptoms will go away. And part of this, the strange thing about this disease is that the symptoms are often episodic for a subset of patients. Like they feel fine, and then all of a sudden they start randomly having chest pain, their heart rate goes up, and they can't walk, and then they feel fine again. And it would drive people nuts if, like, you have this uncertainty about what's going on, and you think you're having a heart attack every second, or you think you're having a blood clot, or you think something else is going on. But unfortunately, that's the reality of the situation.
What I've found with a lot of patients is that, contrary to like cardiac patients or pulmonary patients that we've seen in the past, where our goal is to push them, there's a very, very fine line between, moving forward and setting back. So it's like people could do a minute, 2 minutes, 3 minutes, but that 3 minute and 15-second mark, something happens where it's like a cutoff switch, and it can really set people back. So even with our boot camp, we've had to scale it back significantly. And I think a huge amount of it is inflammation based. And, I have this idea of like sum of inflammation or net inflammation in the whole body. I don't know. It's very, very, so let me ask you this. So besides a chest x-ray, CAT scan, pulmonary function test, are there any other tests that you think, that people should have if they're not finding the cause of their shortness of breath? Or do you think maybe even the test is just not available yet or doesn't exist yet?
Yeah, I mean, so part of the, I would view the workup or the diagnostic test that one does for COVID, or post-COVID, to be just the diagnostic test that someone does for shortness of breath and exercise intolerance, period. And so basically what you're trying to do is evaluate all the parameters that play a role in people being able to exercise. So that includes heart function. So an echocardiogram should be done for people who are short of breath, and that's basically to look to see if the heart's pumping well, if there are any valvular problems, or if there's signs that there are blood clots in the lungs. You can see that if the right side of the heart is failing. And if you have pulmonary hypertension, which is, my field. And then imaging, like a chest x-ray and then a CAT scan is more fine detail. We'll show you some stuff. And then pulmonary function tests are essentially breathing tests that allow evaluation of, how much air can come in and out of the lungs, how well oxygen can be extracted in the lungs. And then, if those are kind of unrevealing, then there are some more advanced tests where, an exercise test, for example, where we can see how much exercise you can do, like on a bike, and see how much oxygen you can use. The more oxygen you can consume, the more, fit you are and everything is working in tune. It's kind of like the Gatorade commercials where people have the mask on the exercise bike, and that's called the cardiopulmonary exercise test. We're actually contemplating doing those types of tests in patients who are short of breath, and having a catheter to measure the pressures in the heart and the lungs, to see what kind of changes are occurring that may describe, patients. That's a little bit more advanced and not something that, we're doing just yet, but that probably will be, what's down the road.
Call me when you're ready for that. I have some ideas too. What about the heart? What kind of heart tests should people be getting? So again, people are getting EKGs, they're normal. People are getting echoes, they're normal. But we're hearing a lot of studies recently about heart damage and cardiac MRI. What could you tell us about that?
Yeah, I mean, it's unclear what that actually means. There are tests that indicate that there may be kind of inflammation in the heart. And if there is inflammation in the heart, it may be what we say is subclinical, which means it doesn't really cause anything. And if it doesn't cause anything and it goes away, that's kind of like a no harm, no foul. If there was, there are viruses that actually do affect the heart really badly. And when they do so, they cause significant heart damage, and the heart stops basically pumping appropriately, and they go into heart failure. We aren't necessarily seeing that. I mean, there are cases in the hospital acutely that we see. It's called myocarditis, and that does happen. It hasn't necessarily been described, frequently in kind of the post-COVID way, in the same way that this subclinical inflammation is that we're seeing.
Some of the numbers of people who are asymptomatic are kind of scary when they talk about how many people's hearts are affected later on. How serious is that? And for example, how worried should somebody be about exercising? Or as clinicians, how worried should we be about pushing somebody during exercise from a cardiac perspective?
I mean, personally, I again, this is based just on Gestalt and the small amount of experience I have, but I think patients should do as much as they can. The two, it's the kind of advice I give patients who have any kind of cardiopulmonary disease, is that the point of exercise is to get short of breath. If you're not getting short of breath, you're not exercising. But that if you develop chest pain or if you develop lightheadedness, those are kind of hard stop, like, that's when we definitively stop. But that you should push yourself to some degree of shortness of breath. And that, we haven't necessarily seen people exercising and dropping dead, post-COVID, at least as far as I know. So I think it should be viewed as a, cardiopulmonary condition of unclear, mechanism, and exercise, should be done. And, you obviously know better than everybody that the point of exercise, I mean, there are 1.5 million benefits for it, but that, with exercise, you're able to basically do more with what you have. And so if you have a compromised cardiopulmonary system and, you can only walk like 2 blocks, the goal of doing exercise and an exercise program is to be able to walk 4 blocks, to walk 10 blocks. I personally, I can't run a marathon, but if I wanted to do that, I would have to train and do an exercise program. And so someone who has, a cardiopulmonary condition, COVID is, a cardiopulmonary condition, the goal may not be 26 miles, it may be, 3 flights of stairs. And so I think that's the goal for exercise. And it's a critical component because that's one of the main complaints that people have is I'm short of breath, I can't do this. And one of the things that can improve your exercise tolerance is exercise, irrespective of what the underlying condition is.
And what about the use of oxygen? So a lot of people, they do desaturate, but they are never offered oxygen in the same way that somebody with COPD or pulmonary fibrosis might be. Do you think they need to be on oxygen?
I mean, if people have low oxygen levels at rest, not moving, they definitely need to be on oxygen. That's an easy one. If people have normal oxygen levels at rest and then their oxygen levels drop with exertion when they walk, that becomes a little bit more complex because, it's unclear whether giving oxygen in that situation, at least on a, day-to-day basis, changes outcomes in patients. We know in COPD, for example, at least in this one study where they did that, it didn't really alter the final outcome of patients in terms of, how well they did in, a number of metrics. I personally think that if you do desaturate and you have oxygen, you might as well use it. I think it also will allow you to exercise more because one of the reasons why people, become short of breath is their oxygen levels go low, and this is a way that can augment that. I would not
Agree. Yep.
not exercise because you don't have oxygen.
Yeah, I mean, we've been very successful with our PF patients and our PH patients by giving them a ton of oxygen. I can't wait to get into the lab and start trying it with some of the post-COVID long haulers. I think we're going to have similar results. I'm going to go to some questions from the chat, if that's okay. Would you suggest that long haulers with recurring symptoms pursue steroids?
I would not. Part of this is, I wouldn't pursue therapies. That's the one thing I would say. I would pursue help. and medical attention. But I would not be your own physician and push for particular therapies. If you find a physician that you trust and explain things well, and then I would go that route. Because part of this is it's very unclear. Steroids are not a benign therapy. They're therapies that we use for inflammation because they reduce inflammation, but they're immunosuppressants, so they shut down your immune system, and you're now at risk for infections. Long-term steroid use increases your risk of diabetes and wound healing and osteoporosis and all kinds of things. So, they should be used judiciously and with people who have experience in terms of what they're doing. Again, a lot of people are extrapolating. I'm guilty of this myself, and giving therapies in the ICU for patients, it was based solely on the physiology that I was seeing and not based on guidelines and clinical trials, because the virus had only been here for 2 months.
Mhm.
And so I think I would be cautious of also the pop media kind of discussions of therapies.
Exactly.
People have kind of learned their lessons with hydroxychloroquine, in that these therapies can be dangerous and may be ineffective. So you have to seek help from people that hopefully know what they're doing, and hopefully they know more as time goes on.
Don't pursue the Clorox, right?
No, I mean, again, you can kind of spray it here and there, but
Okay, got it. Okay. Does diaphragmatic breathing help prevent the lungs from worsening?
Um, I don't think there's any breathing exercise necessarily that alters, you know, the lung itself in terms of inflammation and scarring. I do think exercise or breathing exercises and so on may assist with your sensation of breathing, and how you kind of handle shortness of breath and handle that anxiety that comes when you're short of breath. But it doesn't actually affect, the architecture or anything with respect to your lungs.
So this is a very common question for people with symptoms, shortness of breath, exercise intolerance, but every test comes back normal. Where does that person go?
Um, I, you know, I would probably just follow with a doctor, and there may be kind of a monitoring of symptoms, because at the end of the day, part of this is also to track symptoms. And if you take, other conditions, for example, um, post, classic ARDS or critical illness, or even, things like a blood clot that maybe not be as severe, or asthma, or anything like this, where you may have symptoms that are pretty severe at the beginning. You may have attacks and exacerbations, but there's a clinical course that it kind of follows. And the what interventions are done are based on that clinical course. So it's different if you have symptoms and it's like, once a week you get a little bit short of breath at a particular time of day, versus if you're completely short of breath and you can barely walk half a block, and you used to be able to jog every day. And you want to know the trajectory of how this is going. If the status quo right now is not good, but your overall trajectory is getting better, in medicine in general, that usually means you'll hopefully continue on that trajectory. If things are kind of stable and they stay the same, it may mean that it will kind of stay the same. When you really should be concerned is if things are getting worse. That's when you need to kind of, figure out if something is actually going on.
Can you talk a little bit about the different types of chest pain? One of the things we're hearing from people, between the neck and the gut, we know a lot of people have reflux. We know a lot of people are reporting pain kind of in this area, but it doesn't seem to be the classic chest pain that we worry about, let's say like a coronary insufficiency. What can that be? I mean, it's so commonly reported.
Yeah, I mean, it also, it's very frustrating because, you should be cautious when, as medical professionals, I sometimes don't think we speak well to patients. And in that, when someone says they're having chest pain, our response when we've ruled out the kind of things that may be dangerous are don't worry about it. And that's not really, the important aspect is, in our minds, we're thinking, all right, is this reflective of something that's going to kill this patient, like a heart attack, a blood clot, and then when we've ruled those out, we say, okay, well, we don't really care about it. Whereas the patient's actually having symptoms of chest pain, and that can be disconcerting. And so but from a patient standpoint, it's important to, in your own mind, kind of characterize that in a similar way. There are, pains that are harbingers of bad things, things that are trying to basically, scream for help. And those are things like, the blood vessels of your heart becoming narrow with plaque, and possibly leading to a heart attack. You can have blood clots in your lungs that can be causing that. In general, when you have those, the more you stress your cardiopulmonary system, the more chest pain that you get. And so if you're sitting around and you randomly get a chest pain and then it comes and goes and it's kind of extremely random, that is much less concerning for a cardiopulmonary reason than if you walk and every single time you walk, you get chest pain. Because that's basically saying that when you are asking your heart and lungs to do more, it hurts. And so that's when my kind of ears like go up when I hear, yeah, I get chest pain every time, I walk. That's more concerning to me. Another kind of pain when there's, the lungs don't actually have nerves inside them for pain. It's on the outer portion that have nerves. And sometimes when you get inflammation on the outer part of the lungs, that can hurt when you breathe in. That's called pleuritic chest pain. So the pleura is what lines the lungs. When there's inflammation and you breathe in, it rubs against the chest wall and that can hurt. So sometimes people have pain when they breathe in. The COVID stuff though, it's random. It's pain that's like here, it's there, it's all over the place. Yep. It comes and goes, it's at rest, it wakes them up. It's usually not associated with exertion and doing and stuff. And so that's why, I think, again, this is just my gut feeling that it may involve kind of the nerves, perhaps, that like the nerves are kind of malfunctioning and it's giving the sensation of pain. I mean, not the sensation, I mean, that is what pain is. But that's not to say that, patients aren't experiencing it. It's important to help distinguish that from things that are dangerous. And, as a patient who may be experiencing this, if the important things have been ruled out, you can kind of rest assured that like, yeah, I get this annoying pain. It's annoying, but it's not going to kill me. And I'm just going to kind of acknowledge that it's there, acknowledge that it's not in my head, but that it's the important things have been ruled out.
Many patients report sort of not an immediate discomfort during exercise and sometimes not even a few hours later, but often the next day. So they'll report, particularly post-exertion malaise, exhaustion, and some people's kind of what seem like dysautonomic symptoms come back from that. Do you have a sense of what that could be coming from?
Yeah, and I mean, I was actually just thinking about this yesterday. A lot of these symptoms that I've been seeing are very similar to a condition called kind of chronic fatigue syndrome and a condition called POTS. Which is Postural Orthostatic Tachycardic syndrome. The POTS syndrome is a syndrome where the main problem is that the veins of your body need to constrict to get blood to come back to your heart. And so when you stand up, your veins need to constrict, or when you exercise, they need to constrict to get blood to go back to your heart so it can pump it. Patients with POTS have an abnormality where they can't do that. And so the blood doesn't come back to their heart races, they get short of breath, they may get dizzy and they can barely do stuff. And then this is also associated often with what's called chronic fatigue syndrome, where patients are just wiped out after they do anything, they want to sleep for hours. And part of the issue is that many people don't believe in this disease and they call them they're crazy. And I'm starting to think that this post-COVID is a similar scenario where, patients are being seen by physicians, or all these tests are being done and they're like, you're fine, go on with your life, you're crazy. And the one thing I want to emphasize is that it would be a little bit weird if this many people went crazy. So, clearly there's something going on, and just because we as, the medical community can't characterize it, doesn't mean something isn't going on. I can tell you that a lot of people are trying to put together programs to help, figure this out, and ideally, come up with therapies to mitigate these symptoms and make people feel better so they can do more and get on with their lives. But in the meantime, it involves a degree of patience on people who are unfortunately affected by this, and the symptoms can be very debilitating.
Yep. Yeah, I think, that's the one area where I've started to see a pattern with patients, thankfully. For a lot of patients where it seems like they have these POTS like, syndromes, and, where we could get them, on compression garments or get them really electrolyted up and things like that. That's where I'm hoping to really see some exciting things once we get back into the clinic. What about the role of like bronchodilators and inhaled steroids here? Like, do you think there's any benefit to that?
Yeah, I mean, it's hard to know. I mean, most patients don't really have, I mean, strangely, again, a lot of patients are going to be better characterized with, what's going on. And I think it doesn't seem like, so something like the flu or even like other, respiratory viruses, they often affect the airways. Often people will develop asthma-like syndrome afterwards. And quite frankly, asthmatics are often very at risk for developing asthma exacerbations when they get the flu or when they get these viruses. And that's not what we're seeing with COVID. COVID is not really acting like a true respiratory virus in the same way that these other respiratory viruses are acting. COVID is really like attacking blood vessels in very weird ways, and it happens to be attacking blood vessels in the lungs. It's with respect to like bronchodilators, as far as I know, it doesn't seem like patients really have abnormal airways in terms of twitchy airways that cause them to constrict like you would have with asthma and COPD. If you happen to take it and you feel better, do it. And most I can tell you, most pulmonologists, their goal is to make people feel better. And if an inhaler subjectively makes you feel better, I would use it. I would not use it just because you think it would and it doesn't, because I would only really do that if there's actual evidence that, hey, take it, it's good for you. We don't have that evidence.
PFT evidence or symptomatic evidence?
More like clinical trial evidence. If for example, you said that, post-COVID, if we gave patients this inhaled therapy, even if they don't feel better, 6 months later, they will either,
right.
or something important will happen. Whereas if you take something and you immediately feel better, I mean, I would do it because, there's rationale to do that.
Sure. Are there any supplements that you recommend regularly to patients? Anti-inflammatories or anything?
Not really. I mean, there's nothing that, I think a good, healthy, nutritional diet is important irrespective of whether you have COVID or not. But I don't think there are any real supplements that I could, point out that would have any specific effect.
And as far as cardiac arrhythmias, are there some that you're seeing more than others? Are you seeing things besides just like tachycardias?
Personally, I've only really been seeing just, sinus tachycardia, just people whose heart rate just kind of race. And there are a lot of my colleagues that got sick. It's interesting to be able to talk to physicians who have an intimate understanding of physiology and disease, who go through the disease process themselves, because they speak about it in a different language. And it's really interesting. One of my colleagues, her heart rate would just race, and she was very short of breath, and her oxygen wouldn't go low. And she got the $1 billion workup of tests, and at the end, they were just kind of like, I don't know. And the problem with this disease is that, it is acting, as you said, like a dysautonomia, like the autonomic nervous system isn't working appropriately, hearts are racing. Normally hearts race for reasons that are appropriate, and maybe that this is some kind of inappropriate reason, unclear.
Is there a role for beta blockers there?
Um, if the primary problem is that the heart's doing this by itself, then yes. If the heart is doing it in response to a physiologic reason, then you're blunting that physiologic reason. I've had some
Gotcha.
patients who are on beta blockers, and they actually feel worse. Their heart rate goes down, but they feel worse. And so it's not that the high heart rate is the problem. It's that there's a problem, and you're trying to fix it with a high heart rate. And if you bring that heart rate down, you may be actually causing more symptoms.
Gotcha.
But that's unclear.
Do you think that once somebody gets to a certain point, like for example, once a long hauler has hit, let's say, the 6-month mark or the 3-month mark, are they still at risk for clots? Are they still worried? Do they need to worry about the same things that we see early on?
So far, I think no. Partly because, I basically hear about every blood clot that happens in this hospital. And the thing that was kind of crazy about what was going on early on was that patients would have COVID. They would come into the hospital. They would, be fine and be ready to go discharge. They would go home, and 3 days later, they come back with a blood clot. Or the presenting symptom was that they were having shortness of breath, and then they have blood clots, and then we test them and they have COVID. So it's very clear that early on, COVID increases your risk for blood clots. I have not seen patients who have gone home after COVID months out come back with blood clots. So, and we've had lots of patients here with COVID. So I think that in all likelihood, that risk of increased blood clots is early on and probably wanes precipitously.
Awesome. That's good to know. What does it mean if you desaturate when you're sitting, but when you move around, your sats go up? Deeper breaths?
So, this actually brings up a fascinating point in that, at the risk of not getting too technical, one of the crazy abnormalities that, as I mentioned, we were seeing was that in the very sick people, especially the patients on ventilators, their lungs were not stiff, but their oxygen levels were extremely, extremely low. And so this was kind of screaming issues with the blood vessels of the lungs. And one of my colleagues, she's a neurologist, and we noted that patients had a lot of, especially the very sick ones in the ICU, had a lot of neurologic issues. They weren't waking up, they were delirious, they were on ventilators. And she had this machine, it's an ultrasound of the brain. It's an ultrasound of the blood vessels of the brain. And there's a helmet that you put on. And when you put this helmet on, you can look at the blood flow in the brain, and you can walk away from this machine for hours. And if a tiny little blood clot or something goes by that blood vessel, it'll have a little blip. And so she was hypothesizing that perhaps, patients were not waking up because, they're prone to developing blood clots, and that they were throwing blood clots into their brains, and that we just weren't detecting it. So she put these things on a bunch of patients with COVID in the ICU who weren't waking up and didn't see any blood clots. But what she did do was something called the bubble study. And this is where, a test that's done to look for a small hole in the heart called a patent foramen ovale. When you take saline and put a little air in it and shake it up and inject it in the vein, it should basically go back to the right side of the heart and then into the lungs, the blood vessels of the lungs. And then once it reaches the tiny capillaries of the lungs, because the bubbles are bigger than the capillaries, they should get stuck, and then they should kind of disappear, and you should never see, any signs of it ever again. If, on the other hand, you have a hole in your heart, it will go into the right side of your heart, cross into the left side of the heart, and then it will kind of go to the brain, or some of it will go to the brain, and this machine will pick it up. And so when she did this, she noted that she did 11 patients, and she noted that 9 of them had these bubbles when she injected them. And so it's important to note that only about 20% of people in, world have a hole in their heart. And so when this happened, she's like, there's no way that, this percentage of people had a hole in the heart. And she called me, and I literally had like a cup of coffee in my hand. I almost dropped it when she told me, because what this indicated was that these bubbles weren't going through the heart. These bubbles were actually going through the lung, and it was indicating that the blood vessels of the lungs are abnormally dilated. And so they were abnormally dilated, and they were very similar to a condition called hepatopulmonary syndrome, which is a disease of patients with liver disease where the blood vessels of the lungs get abnormally dilated. And so one of the weird things with hepatopulmonary syndrome is that when patients sit up, their oxygen level is actually lower than when they lie down. Their oxygen level actually goes up. And that's because more blood flow goes to the bottom of the lungs when you're sitting up, and that's where the blood vessels are dilated. And when they lie down, that's what's happening. And so we actually did this study on a whole bunch of other patients, and we're able to show that like close to 90% of patients had evidence of these bubbles, and that the worse your oxygen level, the more bubbles you had. And so one thing that I actually want to do going forward, once I get funding and so on, is to see whether patients, these long haulers, these people who are, post-COVID, are they short of breath because the blood vessels of the lungs are abnormally dilated? And so there's a lot that's happening in terms of, abnormal, blood vessel issues, whether it's in the lungs, whether it's elsewhere, that we really don't know about. If your oxygen goes up when you I think you said when you're sitting, you desaturate, but when you move, your sats go up. There are a number of possibilities, but that, this abnormal blood vessel could be playing a role. That's a good thing though, if your sats go up when you exercise.
So just so I understand, are you saying that the significance of the blood vessel being dilated in the lung is that if it wasn't dilated normally, it would have got caught by the lung? It wouldn't have made its way through the circulation?
Yeah, so the bubble would get stuck in the capillary, and then it would just kind of dissipate.
Be a PE, right?
It's not that it would be a PE, but that it would just the bubbles are very, very tiny, and they don't do anything, and then they just kind of dissolve away. So you never see it again. It's not that the bubbles are causing problem. It's just a marker that the blood vessels are abnormally dilated.
Otherwise, they would have been stopped.
Right. So the lungs are very smart. They try to have the right amount of blood flow going to the right amount of air coming in. If you have too much blood going into this certain amount of air, then that blood doesn't get enough oxygen. So.
Very often patients are having kind of relapses and, remission and exacerbation. Do you have a sense that when they do have these relapses, and I know the answer to so many of these questions is we don't know yet, but do you have a sense that when they do have these relapses that that's actually interfering with their healing process? Or do you think it's just sort of, could it be growing pains, improvement?
Yeah, I mean, I think, my best guess is the virus acutely over a week, 2 weeks, 3 weeks causes some kind of damage and some kind of, lasting effects on different parts of the body, the heart, the lungs, the nerves, the blood vessels, the brain, etc. And in some ways that the body has kind of been rewired. It's almost like if you think about a house that's been put on fire, the fire is the virus and it's causing this damage. But once you put out the fire, you're left with kind of, damaged, parts of the house. And so that area may have kind of exacerbations in the sense that you're not really it's not functioning the way it normally does, and kind of worsens and then gets better, worsens, gets better. But I don't think that's necessarily the virus sitting there causing that problem. And it may be that things have just kind of been rewired, or inflammation has caused changes where things are not, working as they normally would. And the hope is that things would get better, but at the same time, it may unfortunately be, I hate to use this term, but the kind of new normal that may be occurring. And until there's a therapy that fixes that new normal or addresses the symptoms that occur with that, I think the most important thing is to, be insightful with your own symptoms and find out what are the things that provoke it and what are the things that make it better. And, if it is that, I would take, pages out of the chronic fatigue syndrome type playbook.
Yep.
Because there's no real therapy for chronic fatigue syndrome, but there's a lot of behavioral things that can be done that can help mitigate the effects of it, which mean, if you are going to do something, that's going to exhaust you, to allow yourself to rest and not, schedule crazy things the next day, and to, take the stress off yourself by, not being down on yourself that you can't do a lot of these things, and set yourself up for success and not failure when this happens. And it's an unfortunate reality. And, the hope is that there will be a better understanding of the disease, and therapies will help, with the symptoms and the effects. But, in the meantime, the people that know the most about the disease are those that are suffering from it. And so, if do things that make you feel better and try to avoid things that make you feel worse. The one thing I would say is I still do think that intermittent exercise is important. Otherwise, I wouldn't be here. But I think, you have to kind of be in tune with your body.
Last question. What is the role of electrolytes in all this?
I don't think there's any special electrolyte or, electrolyte that needs to be enhanced or replenished beyond that which is the normal situation. I think in general, again, the patients that I generally take care of, they need to stay away from salt, because if salt buildup and fluid buildup and fluid in their body and in their lungs. But in terms of COVID, I don't really know. I mean, I've seen some POTS patients in the past, and I tell them they need to drink as much salt as possible. I mean, eat as much salt and drink as much water as possible. I'm wondering if, COVID is being a similar thing. And I think, if there are kind of patterns that, you notice in yourself, I think that's something interesting to bring up to, people that study this, or, your doctors, and be like, yeah, when I get dehydrated, I get short of breath, or when this happens. And you yourself will kind of know better than others, because right now, no one knows.
Yeah. I want to thank you so much for being here tonight. And I want to thank you so much more for everything that you've done. I know you've been through the ringer, and my heart feels for you. And, I mean it when I say, if there's anything I could do for you, it doesn't have to be medically related. I wash cars, walk dogs, babysit. I'm happy to do it. But I just want to say thank you so much for being here. I know you're busy. I know you're tired, and it's greatly appreciated.
Thank you. And I hope your clinic is up and running soon, because I know, again, of all the therapies that I think patients would most benefit from, after having gone through this, is exercise. And I think, for patients to develop the self-confidence to do so, and to learn the appropriate way to do it, and then also to learn the appropriate way to handle the symptoms that come with exercise and shortness of breath, because the benefits of exercise and cardiopulmonary rehab can't be understated, and that you're able to do more, and then that improves your mood, which then makes you do more, and it's basically this very virtuous cycle. And I mean, I used to send all my patients to Noah pre-COVID, from pulmonary hypertension, and will continue to do so when you open up. So
thank you so much. All right, ladies and gentlemen, thank you so much for being here. Dr. Poor, thank you so much. Greatly appreciated. I don't know why I can't unmute everybody, but Beth, is there a reason why I can't? I want to give him the audio thanks. So thank you so much.
Thank you.
Thank you.
Thank you.
Thanks
All
for
right.
everything you do.
Thank you so much, Hooman.
Thank you so
Have a
much.
great night, everybody.
take
You
care.
too.
Bye.
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 Thank you.